patient who came especially from Kerala in south of India to Dubai to have her rhinoplasty in our center. So she's a typical Indian ethnic nose with thick skin, white tip and large nostril. I hope you enjoy the procedure. Thank you. You see very tiny and very soft cartilage. If you do delivery for this cartilage or open approach, you will be on the wrong page, definitely. With such very soft, very small, very tiny cartilage. So we fully preserve the lateral crust still in place. No marginal incision, no exposure, no delivery of the lateral crust. And this is the best approach for such noses. Preservations, many preservations. Well, mainly working in the midline, as you see, working mainly in the midline already exposed because the septum goes our graft now. There's large extended colamellar strata bridging between the medial cura and the caudal septum. So we are suturing the caudal portion of the colamellar strap to the medial cura. So there is no standard rhinoplasty technique. You have to go with the experience, with the type of cartilage. With experience, you know each patient what type of cartilage he got. With patients with small, soft cartilage, if you do open approach or delivery approach, you are definitely on the wrong page. And it will end later with a lot of healing problem and healing issue. Again. Patients now, people now, surgeons now recently start to realize about the wound healing problem for rhinoplasty, as before many surgeons ignored this point and were working like just technician on the nose, and they forgot that there is a healing process which takes place in the surgical field. It was completely ignored by most of the surgeons because of the lack of knowledge of pathology, which I've been calling for the last 30 years. My colleagues remember the pathology, remember the wound healing process. Nobody was listening, but now they start to listen, they start to understand about the healing process. That's why now people are back to conservation, conservation technique, and to the close technique. Okay, if you got across or in place as you see with some fat, just try to move this fat from there. You see how small and tiny that is, so we did not excise much. You see, we do not need to excise. So this fat. Let us cross approximate construction. You see, now we are transforming from round shape to triangular shape. Go through the anterior septal angle and into the, you see that cast full there, no margin estrogen, no exposure, no delivery, full cast as you see. Full preservation of that cast, full preservation of the alar sidewall. So we are reducing significantly the complication of the healing process along the alar sidewall, like for example, alar retraction, alar collapse, notching, benching. All these complications are reduced significantly with this technique. If you don't see much of this problem following surgery. Again, that across all this. Smooth, smooth. That's one side there. You see that across in place there. Full across, no margin estrogen, no exposure, no delivery. Again, full bullshit. So the back superior septal angle. And now back again. Superior. Also, she has thick skin, but it does not really affect this technique because we established a very strong foundation in the midline, like I-beam of medial cura, intermediate cura, and extended columnar start, and additional columnar and tip grafts. We have 6 structures in the midline stuck together. Look now from the base how symmetry we obtain the symmetry there because of the full preservation of the lateral cast. Give me a sharp double hook. Look now, for example, look at this. The full preservation of that cast there. No margin incision, no exposure. Again, look there. Full preservation of that cast as you see. Okay. And if you look now at this tip from there, base view, and from above, you see how much narrow in definition, and compare with this. Look at this bulbous tip there, bulbous tip there. You see how much improvement we obtain. Again, back here up. Now you see almost half size, or almost half, even less than before. Now we will be just looking at the we switch our columnar strut to the caudal septum. As you see our columnar strut there. And this is the caudal septum. Just remove this mucus and the excess of tissue there. Excess tissue. We are suturing the cephalic portion of the columnar strut to the caudal septum, and that will fix this foundation in the midline to the caudal septum. Another way, fixing the medial cora to the caudal septum, or fixing the tib cartilage to the nasal septum. Now we deal with the nostrils. So now we'll be dealing with the nostrils, marking pen, there it goes, marking pen. Start inside the fold, no lateral, no up, no down, to the A-like insertion with this angle there, and straight line there, section. So mark the first suture. Again here, inside the fold to the A-like insertion with this angle, and first suture. Okay. Within the vestibular skin, as you see. Okay, suture. Already marked our first suture to make it easy for thickness skin. Full thickness skin. See now? Exactly nice, edge to edge. Okay. Right side here. And then that's it. See, coming very nicely. Yes, exactly edge to edge. وغمش شوية. Again, to each. See, almost very symmetric and nostrils as you see. And as you can see now, how many minutes since we are almost done. We will not do osteotomy because she has got short nasal bones, and actually the bony environment is not that wide as you see there. So if you do osteotomy in this case, it will collapse more, and you need to have to put a graft there. So that's more than enough. She had now very small, nice nose, quite small nose, fitting her small face with multiple definition, refinement, narrowing, airline wedge resection, extremely nice result. One, it will be highly descriptive, especially Dr. Sharif for his nice hypotension and appreciation. Thank you very much. This is Bashar Bizrah, Rhinoplasty Bizrah Academy. Only 22 minutes. See, less than 22 minutes. As you see the time. This is our magic rhinoplasty. This is a rhinoplasty for the future generation of the facial plastic surgeon. This is the real preservation rhinoplasty. Thank you for watching.